Arunan will help us out.
Perfect. So we also, Dr. Murli, we also have Dr. Purvi Haria here, who's a radiologist and my go-to person even now at Tata Memorial Hospital. So we've asked Purvi to join us also and give her opinion on some of the things. The way we approach this webinar is that it's all about what we are going through in the clinic. We put up certain concerns that we see in the clinic. These are real world scenarios. It's very nice to know evidence and literature, and sometimes we are still baffled because of the cases that we see. So it's where we get the experts together and just what we could have learned from any of this. So another 5 minutes literally, and then we'll start. We're at 7 we're going to start the webinar. Thank you.
Okay.
Hi, Preeti, will you be presenting or will Dr. Geeta present?
Hi, ma'am. I will be presenting.
Okay, so can we also make Preeti a co-host? And then we're just waiting for Devashree's team to come online and we should be ready to start.
Ma'am, I'm here.
Okay, perfect. So let's make Devashree co-host also, please. So the order we are going to go in is we're going to start with Manjula, then do Geeta's group, and then do Devashri and Selvi's group. Has Geeta joined?
Ma'am, not yet. She's just joining.
Okay, so we'll just wait for Geeta and then we'll start.
Okay, ma'am. Okay.
Devashri, if you can raise your hand, then they can make you co-host. They don't think they can find you.
Hi, Nita, ma'am.
Hi, Jay.
In the meantime, ma'am, what is this, ma'am? This
So I am actually
masterclass
just waiting
series.
for
If you can
Geeta
tell
to.
something about that.
Yeah, I'm waiting for Geeta to come online so I can start.
Sure, ma'am. Thanks.
Just a second. I promise you, I will tell you everything about it.
Yes, ma'am.
So Princey, Debashree's put up her hand. She's tagged as Shiva. You can make her co-host also, please.
Okay, ma'am.
Thank you so much. Okay, so now that Dr. Geeta is also online, I take this opportunity on behalf of the CBCS group. We have both Dr. Shona and Dr. Geeta here. We had created this group a few years back, if you remember, and we've been trying to get together our act both on data as well as education. So Geeta is going to take us through 2026 with a very exciting year on more data collection and projects that we're doing as a group together. You will see a lot more from us. We have not disappeared. We have used this webinar series to remind you all of certain things that we've kept in mind, which is clinic to basically science to clinic and making sure that we've all got real world scenarios. The next effort in our educational series, the webinars will continue, but is also the masterclass series. And the masterclass series is something that we're going to do as small groups. You can see that we put up 4 for the coming year. These are the topics that we're going to approach at each of these cities. The masterclass series is going to be in person. It will have a nominal fee with it. But the idea is to do a sort of in-depth discussion on each of these topics. The first of which is going to be in January, along with the YIR. We're going to do it on the 23rd of January in the evening. Since many of you will be attending YIR this year, we hope to also have you join us for the conservative mastectomy masterclass. Our approach is going to be to discuss much more than just the flowery benefits of it. We hope to bring out even the nuances of what to expect, how to deal with complications, when not to do it, and when to offer any of these. We hear a lot about minimally invasive mastectomies. We hear a lot about all the various reconstruction options because we've started doing more nipple sparing and skin sparing mastectomies. But as a group, we want to keep it real and have many of our experts come forward and tell you what can also go wrong. And they'll give you their tips and tricks, and we all hope to learn a little from that. And I can tell you that having just started into whatever's robotic mastectomy as a series, we've done our second patient with a bilateral last week. There's a lot we still don't know. And there's a lot that we really need to be careful about when we plan our patients. A lot of things that we see that we don't talk about, nobody talks about their morbidity. We want people to come forward and discuss it so that everyone's very aware before they jump into it. Oncoplasty has a great role for our patients, but we need to be very cautious about whom and how we plan it for. So that's going to be our first of this masterclass. The second Shona is going to take forward in April on the role of TDXT in first line and sort of in the first line setting, because now suddenly it's become the wonder drug that we're all talking about. Geeta is going to take the third one in August on multidisciplinary meetings, and we're going to try and bring in some students also to present for that. And we're going to end the year, sorry, that's not September, it should read December. We're going to end the year with a masterclass on sentinel node biopsy by Selvi's team. So today, sorry, we're going to go back to our webinar series. I'm going to ask Manjula's team to share. Sorry, we have a few exciting cases, completely dumbfounding us in clinics, and we have a bunch of experts who will join us for that. Manjula.
Yeah. Sai, could you please start sharing?
Yes, ma'am.
All right. Dr. Neeta, can we begin, or would you like us to wait for
No, we have
5 more
everyone
minutes?
on board. Please go ahead.
Perfect. Okay. Sai, can you put it on slideshow and then start the presentation, please?
Yes, ma'am. Yes.
Sorry, Sai, just before you start, a couple of requests. We don't do this webinar as faculty separate and delegates separate. So the idea is to be interactive, but we can't have too many questions happening at the same time. So if you have a query, please raise your hand or put something in the chat box. I will address it with the team. Also, try and keep your self muted so that there isn't any disturbance to whoever's presenting. Thank you.
Can I start,
Go
ma'am?
ahead. Yes, please.
So our first patient is a 58-year-old postmenopausal lady who presented with complaints of lump in the left breast, noticed since June 2025. She was initially evaluated at a hospital, following which she took second opinion from another hospital and then came to Apollo Proton with the following reports. So these are the reports from the first hospital. Mammogram done showed a 0.7 into 0.7 centimeter round cystic lesion with fine spiculated margin in the subareolar region of the right breast. This was a Birat's 4B lesion. On the left side, there was an ill-defined hypoechoic lesion which measured 2.1 into 1.4 centimeters in the retromammary region at 12 o'clock. There was extensive parenchymal distortion, hypoechogenicity, and calcific foci scattered in the upper quadrant from 10 to 2 o'clock, and the lesion was a Birat's 4C. There were enlarged nodes with thickened cortex and preserved fatty hilum in bilateral axilla. Now, the core biopsy from the first and second hospital, there was a discrepancy. So the core biopsy from the first hospital showed on the left breast scattered atypical cell clusters, but the tissue was too scant to perform an IHC. On the right side, there was an invasive breast carcinoma, which was grade 2 and triple negative on IHC. Whereas from the second hospital, the core biopsy suggested a high-grade DCIS, just a second, with scanty focus of invasive breast carcinoma, grade 2. This was HER2 positive, Ki67 was inconclusive. While on the right side, it was an invasive breast carcinoma, grade 2, with chondromyxoid stroma, and this was triple negative on IHC. She presented to Apollo Proton, and clinically, in the left breast, there was a 4.5 into 4 centimeter lesion extending from 12 to 2 o'clock radian, also extending inferiorly into the retroareolar region. The nipple was found to be involved, overlying skin appeared free, and there was a single palpable node in the left axilla, which was almost 1 centimeter in size. In the right breast, there was a vague mass at 12 o'clock, which was 2 centimeter away from the areolar margin. And the mass measured 2.5 into 2 centimeters in size. The overlying skin was free. There were no palpable axillary nodes on the right side and no lymphadenopathy in bilateral supraclavicular fossa. So clinically, bilaterally, it was T2, N0, M0. An MRI breast was done, which showed on the right side an irregular linear enhancing lesion at 8 to 9 o'clock position, which was 1.5 into 0.4 centimeters, extending into the subareolar region. On the left side, irregular linear enhancing lesions were seen involving all the four quadrants of the left breast, predominantly the upper outer quadrant, and this measured 5.6 into 8.7 into 4.4 centimeters in size. There were bilateral prominent axillary nodes with asymmetrically thickened cortex, the largest on the left side, which was around 0.8 centimeters in size.
You have a routine mammo of this patient? Sorry, Sai.
Do we have
Sorry?
a mammogram?
No, so her mammogram was done in the other centers. She had one done at the other hospital, and Cancer Institute, they don't give the mammograms. So this was, I think, 3 or 4 months ago. So we don't have the physical mammo with us. She had the films with herself. So
What
because of that,
prompted
we
the
got an
MRI?
MRI done here.
Why MRI?
Sorry?
Because she was young,
Hello?
you decided on MRI.
No, she's not. Yeah,
How old is she? I'm
I'm
so
not going to
sorry.
comment on the age. She required an MRI because the presentation, or I think she had the lesion on the right breast which they commented upon in the ultrasound, was actually not palpable, and it was also not evident on the mammogram. It was missed out in the first institution as well, which is why we decided to get an
Okay.
MRI done to get more clarity.
So here,
Okay,
this
so
is the
clinical
one, right?
radiological discordance.
No, no.
Sorry?
So, sorry, I just wanted to know. So this lesion that we can see in the upper image below, that's
Yes.
the right breast, right? Or is that the left?
The one with the extensive disease is the left, which is to
Correct.
our right.
Yes, correct.
And and just that hint of that white thing on the left is actually the right breast.
Okay, okay. And there is no calcification or anything here, right?
No calcifications. It was very, very unobtrusive. In fact, on clinical examination, I felt a lump at 12:2, which on imaging that was nothing except for breast parenchyma. This particular thing was more around 9 to 10 o'clock. It wasn't palpable at all.
Okay.
Yeah, Sai, go
Can I
on, Sai.
continue? Okay.
Yes.
So a block review was done at our hospital, which showed on the left side microinvasive ductal carcinoma in the background of extensive DCIS. This was grade 1 with a low mitotic index of 0 to 1 per 10 high power field, and on IHC it was HER2 positive. On the right side, it was an invasive ductal carcinoma grade 2 to 3 with a mitotic index of 0 to 1 per 10 high power field, and this was triple negative. PET-CT was done, which showed no evidence of distant metastasis. There were mildly metabolically active multiple left axillary nodes with preserved fatty hilum, prominent right axillary nodes with no significant metabolic activity, lightly reactive. So even though she had a triple negative lesion on the right side and a HER2 positive lesion on the left, in view of low mitotic count and microinvasive component, we decided to go ahead with upfront surgery. A breast conservation was feasible on the right side. However, the patient chose to go ahead with bilateral mastectomy. Hence, she underwent bilateral mastectomy with sentinel lymph node biopsy. Following this, the final histopathology was reported as on the left breast, it was an invasive ductal carcinoma in a background of DCIS with 3 invasive foci, largest measuring 0.4 centimeters, grade 1 with a mitotic index of 0 to 1 per 10 high power field. Pathologically, T1A, N0 lesion, and IHC was reported to be HER2 positive. On the right breast, it was a cellular neoplasm with chondromyxoid features, and the lesion measured 2.3 into 1.8 into 1 centimeters, and the following markers were positive: cytokeratin 5-6, S100 and P63, SMA was negative, and a diagnosis of pleomorphic adenoma was made.
Can I request Dr. Sushma to take the discussion forward with regard to the pathology, please?
Yeah, sure. Thanks, Manjula, and thank you, team, for giving us the opportunity. And I will go very briefly with the case first. Any questions at the end of the slides, you are welcome to ask. And we got the first on the left-hand panel of the screen you are seeing is the biopsy sample. And by the time we received this, it was a very, very small sample. And you can, right now it looks big on the screen, but it was barely 3 millimeter size. It had got cut several times and IHCs were done 2 rounds. So what we had was this much. It was actually very difficult and challenging case for me, to be very honest with you. I had never seen this kind of a hyalinized background, and I just said that this looks very suspicious, but somehow I was not very comfortable coming out with a straightforward diagnosis of an invasive carcinoma. I told Dr. Manjula, let's get this out and see what exactly it is, and then we will figure out what the final diagnosis is going to be. I don't think this small biopsy will give us a confirmed diagnosis, or we have to go back and re-biopsy it. On the right-hand side, Dr. Manjula was kind enough to do the excision and give the specimen to me. And in this case, when we observed, there was a diffuse area of fibrous density in the retroareolar region, spanning about 7.5 by 3.5 centimeters. And when we looked at it very closely, we found this lesion in the middle of that area which we had a fibrous density. This was around, if I remember correctly, it was around 2 centimeters size altogether. And you can see that this is a very well-defined lesion, and part of the lumen is still not occupied. And you can see the dimension, the periphery is very well circumscribed. And in the center, at this power, you are not able to see a whole lot, but there is a bluish pink area here. Next slide, please.
Dr. Sushma,
Yes.
can I just tell you, can you go back to the first one?
Yeah.
So according to me, there's a duct lining here. You can see a nice, so I mean, the thought process I am having is this is likely to be a papilloma with chondroid metaplasia, which is
it could be, yeah.
Because actually, I'm sorry, I didn't realize it earlier when you were describing just now. I realized that there is a gap between the wall. So,
exactly.
That explains, see, if it is what it is, and you know, some of us know the diagnosis.
So it was like, I'll come. I have a few more slides. Let me finish, okay?
Sure.
So that if you look at the biopsy, you will be very tempted to call it invasive. But there was something about it that was bullying me, not going. That's why I hedged and gave a diagnosis cellular neoplasm with that chondromyxoid features I gave. I didn't come clearly with the malignancy, and I clearly understand this will cause a lot of discomfort to the clinicians not knowing what to do. I said we have to get the whole thing out, whatever it is what I suggested to Dr. Manjula. Next slide, please. I'll show you. You can see here, there is in the left-hand panel, there are two slides here. On the left-hand side, you can see one half of the slide looks very cellular. Another half looks almost acellular with this area that looks bluish pink on this side. And you can also see some cells that are entrapped. I'm not able to understand if you can appreciate the entrapped cells here, single cells in the background. And the right-hand side, you can see that the area, what you are seeing, I have highlighted in blue line, is the area where the biopsy needle had crossed. And you can see the displaced benign clusters of cells. This, for anybody who is not trained enough, can easily mistake it for a focal invasion. But we have to always bear in mind, whenever there is a biopsy performed, we also always have some cells displaced. And we should not go on the limb saying that there's a focal invasion. So I just highlighted, if there are students, to know that this is what sometimes can be seen in the biopsy, and we can be caught off guards. And knowing that there was a biopsy prior will be very helpful. So this is the site where the biopsy had gone. So we had the lesion, what had been biopsied earlier. That's what I meant. Okay, next slide, please. Sai, next slide, please. So we went ahead, and we said, to me, it looked like a pleomorphic adenoma, to be very honest with you. I'll make an honest confession that this was my very first case of pleomorphic adenoma in the breast. I have seen a lot of variations of the intraductal papillomas, but to prove it, I told Dr. Manjula, my suspicion is that this is a pleomorphic adenoma, and let's prove it, is what I said. So we went ahead and got all the markers for this, necessary ones. And you can see that on the left upper hand side, there is a smooth muscle positive in the basal cells. P60 also is positive. The key marker was the S100. Okay, S100 highlighted nicely all the cells, and including those cells that were caught in the hyalinized stroma, the chondromyxoid stroma. That was the key for us, because these are the ones that will, S100 comes positive in a regular pleomorphic adenoma also, and if it happens in the breast or anywhere else, we can get it positive. And we did 3-4 markers, and the point I want to make here, the presence of the basal cells will essentially exclude a malignancy. Any ducts, any tubules that have a basal cell and the luminal cells, they usually take off the malignancy out of the picture. So this is what I wanted to highlight. And also these cells can sometimes, because they are myepithelial cells are known to be positive for CK5/6. They can be positive for basal cell markers and SMA. These are known markers for basal cells. And S100 was the key marker for us. So we went ahead and I told Dr. Manjula, this is indeed a benign process, and it is showing S100 positive. With the morphology that we are given, I am going to make a case of a pleomorphic adenoma. However rare it's the best, but it has happened. We have one case like this. Now, this is the pleomorphic adenoma. Next slide, please. Okay, so this is the pictures I put to compare the slide of ours from the salivary, very common salivary gland neoplasm. Top two panels are showing the low power and high power. On the left hand side upper, you can see the gland with the acini. On the left, on the other half, you can see a very well delineated neoplasm, which has again chondromyxoid pattern here. And on the right hand side, you can see the same myoepithelial cells that are forming the tumor here. And below is our case. You can see how similar they all look at one point. So I just wanted to show and compare that this looks almost similar to what we see in the salivary gland counterparts. So given the non-invasive pattern, presence of the intraductal position, and plus having the immunohistochemistry stating that it is not a malignancy, and S1 coming positive with a chondromyxoid area, including those small single individual cells, we made a case of a pleomorphic adenoma of the breast. And that was the diagnosis in this case. It is a benign condition. And in addition, we found small other benign stuff around this area also. And but we did not find any other invasive component in this case. We thoroughly searched for this case. Okay, so this was the final diagnosis we offered, saying that this was a primary, pleomorphic adenoma occurring in the breast. This is honestly my first case officially I have diagnosed. I have seen in conferences, but personally, this is my first case. How rare? These are very rare lesions. Over to you, Sai and Manjula.
Next slide. What do we have? Do we have any more images? No, right? Okay, all right. Go back to the images, please.
Yeah. So Manjula, before you go forward,
any questions?
Manjula, yeah, before you go forward, I'm going to ask a couple of questions, which I'd like both the radiologist as well as maybe the pathologist to help us with.
Sure.
As a clinician, I have a patient who has a palpable mass. Radiologically, there is some suspicion of it being abnormal. And there is a biopsy from outside that says it is IDC. How often am I going to review blocks for every patient? Not all patients are willing to review blocks. Most come with definitive diagnosis. And was there something radiologically or clinically that should have drawn suspicion, saying that, yes, please repeat a biopsy at your center? So Manjula and maybe your radiologist.
Dr. Arnan, would you like to just take this from a radiology point of view? We haven't done a mammo or a repeat biopsy at APCC. We just got an MR done to get more clarity on the image. Dr. Aruna?
Right. So I would treat this as IDC then and operate, right?
Yes.
So then to be thrown up with a new diagnosis that, hello, this is benign, can be very unnerving in the clinic. So Dr. Arnam, maybe you can help us on what.
But if you look at the history, the patient had a problem on the left side. The light was an incidentally picked up lesion, and Manjula kept saying that she could not palpate. And that's your first clue, right? Manjula, you said that you could not palpate anything on the right side, right?
Yes.
And
yes, but that being said, on the imaging, be it from the other hospital or the reports from Cancer Institute as well, it said that the lesion size was very small in the right breast, only 0.7 into 0.6.
Correct. So,
and that being the case, I did not expect to palpate it. So even when that 2.2 centimeter, whatever I could feel at 12 o'clock, when Dr. Arunan told me there was nothing, I didn't give a second thought to it. Because for me, this was a subcentimetric lesion, non-palpable. We go by imaging. So I got it wire localized. No, sorry, this was a mastectomy, no? So we did not do a wire localization. Though we did keep trying to push her for a BCS. So I did talk to Dr. Arunan about a wire localization at that point. And when the final pathology came out as pleomorphic adenoma, I was thrown because we did a mastectomy and the report came benign. Then we went back, we reviewed, and we realized that there were two other institutions which had called it an IDC, and I sort of heaved a sigh of breath. Dr. Aruna?
The main problem here is that you don't have a palpable mass. Actually, according to me, this is a papilloma with chondroid metaplasia. It's an extremely rare thing. That's why you could not palpate it. It was a duct with a impacted thing. I am surprised that somebody managed to get a core biopsy from them. And a lot of this calcification, if it's a pleomorphic adenoma, you have to have some kind of chondroid matrix, which is seen in mammography. Whatever 1 or 2 cases we've seen calcification is one of the very important thing. And that's why I asked you if there is a routine mammography, calcification would have been a good clue that something is not right, that IDC is, and of course you can get a very rare osteosarcoma, but that, whatever it is rare. According to me, this is a papilloma which you detected. Was there a chance that the patient had nipple discharge in that breast and something
No,
like that?
completely asymptomatic on the right breast. And it's interesting you should say that you think it's a papilloma with chondromyxoid features, because one of the reports was IDC with chondromyxoid features. And that was one of the reports. And Dr. Arunan, when he did the imaging, I'm going to ask him to take over actually now, but I'm just going to mention that he specifically, so I discussed the imaging with him before I talked to the patient, and he specifically told me, Dr. Manjula, there's no lesion there. It looks like a duct.
Correct.
And I was like, they've done a biopsy. There has to be a lesion. Duct, what do I do? Yeah, Dr. Arunan, would you like to?
Just a second. So Tanuja, you said that 7 millimeters. How can you even biopsy? So what is visible on ultrasound can be biopsied.
Yes.
It does not matter whether it is 3 or 4 or 5 mm. If you
So
can
Geeta,
see it
just like the spider sense should click when you have something that is non-palpable. You're getting a grade 2 IDC, which is a TNBC with a metaplastic stroma, because metaplastic TNBCs are well palpable. So all this.
so that is true. I completely am on board with you. Meaning that such a small lesion, why wouldn't be?
Papillomas can do all funny things.
Yeah. So you have to be, so if you are already reviewing what is happening from the outside, so we've had these situations when patients have with FNACs which have said ductal carcinoma, and and then you finally find that it may be a granulomatous mastitis or maybe nothing at all. But my only thing is, so we've done a mastectomy for her. That is kind of
correct.
Too much of an extreme for me to kind of get my head around. Although I know, I'm sure you would have had that discussion with the patient also, that this may turn out to be something which we do not know what it is finally going to be, and it may be actually quite radical to do a mastectomy.
No, so the discussion that we had with the patient was, before I go on to that, I think Dr. Arunan, if you could just tell us what you thought about the imaging, and then I'll. Yeah.
See, we started off with the background that the patient was diagnosed with a carcinoma on both breasts. And the left breast was classical. You had the ring and arc enhancement along the ducts involving all 4 quadrants, and the lesion in the right breast, it was at 8 to 9 o'clock position. It was somewhat similar to the the findings of the left breast, although it was just a focal finding only at 8 to 9 o'clock position, and it was enhancing along the ducts, and there was a small nodular lesion at the end. So keeping the the left breast findings also in mind, and it was proven to be a carcinoma. So we just thought that even this was also a similar appearing lesion. If I was given another chance, I will still call it a BIRADS 4. I will not go down to BIRADS 3 or 2 still, but I will still say that it was still a very suspicious lesion at 8 to 9 o'clock position. And the left breast is classical, I think a 4C or a 5. Yeah. If I saw it without the biopsies.
So Dr. Arunan, your right breast enhancement pattern looks very, very ductal, doesn't it?
Yes, ma'am. Yes, ma'am. It is along the ducts. Yes.
So the nodule that you're seeing, the way it is oriented, it almost seems like it is. See, in hindsight, we can always be very, very wise and clever, but it looks very ductal.
Can I jump in?
Yeah.
Sushma here. I just wanted to tell you, because this is a very challenging diagnosis, and those cells that are entrapped in the chondromyxoid stroma can very clearly mimic a metaplastic carcinoma. And literature supports that there is pleomorphic adenoma of the breast are often misdiagnosed as a metaplastic carcinoma of the breast, because it has all these chondroid lesions and everything. But when the one thing we always have to do is correlate with radiology, because a metaplastic carcinoma would never look like this, what we are seeing on the imaging. That's when we took a step back. I said, this is not looking like a metaplastic carcinoma, and this has to be something else. This was the first time I got a doubt that we are probably not dealing with a neoplasm what looks like a metaplastic carcinoma.
So
That is why I hedged.
So you had an intact myoepithelial layer and
Yes.
chondromycoid, so that
Yeah.
rules out
Because
the
because see, I will not blame any pathologist, because this is a very challenging diagnosis. If you see single cells or a small cluster of cells that are in a background like this, it is nobody will think first as a pleomorphic adenoma diagnosis. Believe me, the
Dr.
tissue was
Sushma?
small for us.
So
yes. So I'm just trying to tell that
okay. Am I audible?
Yes,
you are.
Yes. Okay. So Dr. Sushma, great. Please carry on. We couldn't hear you.
Oh, okay. So what I'm saying is that the way it presents on the slides, this is a trap for all the pathologists. If you think that something, especially if you don't correlate with imaging, these kind of things, when there will be a doubt, and if it is metaplastic or anything, please be certain that we go and somehow check or call the doctors, either the results or the clinicians, to think that does it patient look like a metaplastic carcinoma. So we have to always take one step back, and then imaging plays a very big role in this case, because we are stuck with calling small cells in a small core biopsy. It is almost certain any pathologist will think of a malignancy first.
So now, Dr. Arunan, did you have anything else to add?
Nothing, but I will still call it BIRADS 4. I mean, if it was given without the biopsy reports.
Okay. So I'm just, Dr. Neeta, because Dr. Geeta had asked, I'm just going to talk about the conversation I had with the patient, and that would also answer some of the queries in the chat box. So what we told, I'll tell you, I had no doubt about the diagnosis. I didn't even think that this could be something benign or, non-cancerous or even a papilloma. Because I had two reports telling me that, it was ERPR negative and IDC, and we got it reviewed here by another pathologist. And, I have a lot of faith in, Dr. Sushma's reports. And so I didn't even think that it could be otherwise in the setting of having, extensive involvement in the left breast. So, I didn't think this could be something else. But the conversation that I did have with the patient was, I kept telling her that, look, you've already had two biopsies and now there's very small enhancement. So, whatever little bit I take out when I do the conservation, or even when we do a mastectomy, it may turn out to be nothing at all, because the core may have already removed whatever was there. But because they were having a mastectomy on one side, she wanted a mastectomy on the other side. Secondly, because the contralateral side was so small, the right side, the lesion was, subcentimetric, they wanted to actually avoid radiation. So she said that, no, I don't want to, in case, there's a chance for me to avoid radiation, I don't want all of this. Just do a bilateral mastectomy. There was a lot of anxiety that was involved. The other question was, did we do BRCA? Yes, we did do genetic testing, because she was triple negative on one side, and also because there was bilateral involvement. Most of our patients routinely, we end up sending them for genetic counseling and testing if they, if they're keen. So that came out as negative. And rebiopsy with a VAB, I did not even think of a rebiopsy, because she's had two biopsies and she's come. This was the third place. And because of all these reviews that they've had, she came to us after 1.5 months. So she spent 1.5 months just running between two hospitals, and we were the third hospital. And when I looked at the extensive involvement on the left, which was, HER2 positive, and I thought the invasive component would be greater when we finally do operate. I was not keen on any delay, so I did not discuss VAB with her at all, because I did not doubt any ambiguity in the diagnosis.
So, I'm going to actually put out something here. Assume she had HER2 positive disease on the other side, which was extensive invasive, right? You had microinvasive, she had a large palpable mass, proper invasive disease. We would have potentially given this patient chemo first.
Yes, that was also the discussion. So we have our MDTs. So I brought this case to the MDT, and I also recall discussing with Dr. Sapna that I had actually planned, and So here's an interesting
No,
point.
so here's
In
my
one of
point.
the
Had we
hospitals,
given her chemo first, we would have just assumed that the right side has responded to chemo and actually there was small disease there.
exactly. So in one of the hospitals, the first hospital, they got the investigation done and then they went off to the other place. The other hospital, she was planned for a bilateral mastectomy when she came to see me. And I recall looking at the report and I said, hang on, it's HER2 positive on the left. So I'm not going to say upfront surgery. You require chemo first. And then we took time to review the blocks and, we were going back and forth. And then finally, I'd actually already told them, please meet the medical oncologist. And then finally, we came back to the same, we had the same, we came the same surmise that she had to undergo bilateral mastectomy. So again, at that point, I was thinking, oh no, what did I do? Like I told her, don't just hang on, because you require chemo first. But we did do a mastectomy for her finally upfront.
So here's my thing, I mean, we need a learning from this case. What could we have done differently now in retrospect?
It is clearly that the radiology and lack of palpable disease should make you.
But
So
madam, we see a lot of non-palpable disease. I see a lot of my average tumor size now is.
So, I mean, we have also borne on our cases. So, we once in a while, we've had an adenomyoepithelioma ulcerating the breast and looking like an IBC. This is a rare case, but in this case, one interesting thing is that this was a very, very small lesion. So, if there was any doubt in diagnosis, best would have been a wide excision and then follow up. That would have been
But Dr. Tanuja, we did not have any doubt about the diagnosis.
Correct, I understand.
Secondly,
I know
because
what you mean,
in the
Manjula.
setting of a cancer on the opposite side, and I agree she was IDC grade 2 triple negative, but we see a lot of grade 2 triple negatives with low Ki67. So I thought it was one of this. I didn't even think
I
it
don't
could
know.
be
I think
something
in
else.
TMH we've given this thing that at least get one review. You know what I mean?
Yeah, but so
I
see,
always
that's the thing. Patients who come to TMH will because it's not like they have a choice and they're told that you have to review every block here, right? We don't repeat imaging.
in outside hospitals. How do we catch it? Yeah.
So it
Every
depends.
hospital.
It also depends on where the biopsy was done. So if I get it from a good institute, I may not
Agreed.
review
So
it.
one of them is
If it's an All
Adyar.
India Institute or a
Yes.
Rajiv Gandhi, I would not review it. So
But that's what I'm saying.
Both
So one
both
of these is Adyar.
pathologies both pathologies are from good institutes. One is a corporate
that
hospital.
is fine. So this,
The
I
lab
would.
was a good one.
So I
And
would.
second was Adyar.
Yeah, so I understand. So you would not. I mean, I would also not have kind of doubted what they did.
So
The only thing different I would have done is just as Neeta said, for such a large lesion, I would have done neoadjuvant chemo and targeted and clipped the other side because just because we do not know what is going to happen to that, and maybe yeah.
So,
Alexa.
ma'am, what happened was for the left, we were initially planning chemo, and then we realized that it was extensive DCIS. So, which is why we decided to go ahead with a mastectomy to find out what exactly is happening, to stage the axilla properly and check the volume of disease on the
So that's
left.
true of all HER2 positives, no, Manjula? You would have extensive DCIS. A large number of them. You would have pleomorphic calcifications, large.
Geeta, she didn't
No,
have a
ma'am, there
proper
was
invasive. She
no.
had micro-invasive.
This was micro-invasive, ma'am. It was not upfront
She didn't
invasive,
have a
and
diagnosis
it was
of a
node
proper
Never
negative.
had an invasive on it at all.
Which is why we that's why I told her, because initially plan was NACT. And I told her, wait, don't get surgery done. It's you require chemo first. And then I had to backtrack. I had to go back on my own word and tell her that you require surgery first.
You will get these outliers. I don't, and if once the patient is clear, it is really sad that, she had to lose a breast for a benign thing. But then, there is a point of time when you cannot kind of dig further. So you land
So I think Dr. Moo has asked, how did you explain that to the patient? So one thing was the patient was extremely anxious. I told them that initially itself that when we remove the breast, there's a high chance that there may not be any disease, or you might get a very small, like a micro-invasive sort of component. I mean, a very small size disease on the right. They were okay with it. And when the report came out and I told them that, this is actually a benign lesion, and you don't have cancer on that side, they were very happy. she was not concerned about losing her breast at all. So I was pushing her for a BCS wire localization on the right, and but she's even now she's very happy and she's like, thank you, you saved my life. But it was us and in the MDT where we raised eyebrows and we were very upset.
I'm going to say, I think my learning from this is cases with any ambiguity, if not all, must go through the MDT. I think that's my learning from it. When there's, even an iota of like something doesn't look the same as it should routinely, has to be discussed in MDT. Somebody may be wiser in terms of being able to throw up something in
At least a
radiology.
second opinion.
Different.
At least
Pathology.
rediscussion. Yeah, at least some rediscussion. See, I always say, so mistakes happen. This is a rare situation. I mean, we accept that. But I always tell the clinical unit that pathologists can, we can all make mistakes because what is presented to us can be totally different at given point of time. It's the clinicians as spider sense that something is not right and let us get a second review. So one privilege we have in Tata is we have 4 or 5 people. So you call, in fact, Neeta had a golden rule that phyllodes in young children get a second review, certain golden rules, papillary tumors, atypia or something like get a second review. So certain things you have to have a second pair of eyes, if not one. And with radiology, pathology and surgeons all coming together and discussing. I think that's the move.
I also think what Dr. Sushma said was very sensible, is that your pathologist needs to know that, there's biopsies been done from which area. They need to be more tuned into the fact that if there is a biopsy done, cells could sort of look like invasion. And it needs to be a discussion that happens with them also.
Yeah, agree.
Right.
So, Dr. Tanuja, I just wanted to ask you, now you said that mistakes can happen. So now, would you still call this a mistake because one center has reported it as IDC with chondromyxoid features. It's come as TNBC. And also literature says the very few case reports that we have that pleomorphic adenomas of the breast usually can be mistaken for metaplastic CAs or chondromyxoid tumors. So could this just be the case of a tumor mimicking something else because, it's such a rare scenario? Or do you still think that there should have been something that could have alerted us?
So, Manjula, before you go to Tanuja, I wanted to ask a question basically for Dr. Sushma. How did you mark out this area? How did she figure out where this area was? I mean, because it's very tough because this is barely 5 millimeters. What did you do to make life
I can tell you, I was sweating in this case.
Because it is tough. So, we are doing
I'm telling you, I had my doubts set up front, and I told my junior staff, I said, I want to be present at this case, and I wanted a 5 millimeter thin slices done, and we have gone to the bucket several times. Believe me, this was not an easy case for us because of the index of suspicion for me was so high. I wanted to ensure, So we had to piece the. We have gone twice to the bucket.
What we have done. What we have done amongst us is, when there are these impalpable lesions, and and we are trying to help our pathologist to figure out where it is, and so especially in a mastectomy, it is really tough for them. So we have started, so our radiologist, so the specimen goes to the radiologist first, and then she puts in the needle into the area. She does an ultrasound of the specimen, puts a needle into that area, and then it goes to the pathologist. And the pathologist is also there when she's doing the needle so that she knows exactly.
Many times we have done specimen ultrasound. We have done many times. We have done ultrasounds on specimen.
Yes.
Specimen ultrasound is the best way if you don't find the lesion.
Yeah.
Manjula, can we move on to the next case? We're really
Just to think, I think, Anita, this is actually a papilloma with a chondromyxoid stroma, and that's why it was not palpable. And what we should do is that we usually do myoepithelial markers. So if somebody had done myoepithelial markers on the core biopsy, so anything that is suspicious in the breast, we do. Most pathologists do, but I think something went misleading somewhere, and that's how we probably in the core biopsy it got called as a TNBC. But according to
Neeta, we are already at 7:50.
Chalo, chalo,
Yeah,
chalo.
we're going to
Okay.
just
Sai, can
so
you present the next
Manjula,
case,
Dr.
please?
Manjula,
Yes, ma'am.
maybe we jump to the next group and we'll come back to you if we have
Done,
time.
done.
All
Done.
right. So Sai, if
Perfect.
you can
Sai,
unshare
stop
and
sharing, please.
Yes, ma'am. 1 second.
we can get Preeti to put up her set, please. Thanks.
No, so you have to give me sharing rights.
Yeah, so
Preeti
Preeti was
doesn't have,
sharing.
Preeti doesn't have the slide set.
Yeah. Can we make Geeta co-host, please? Princey?
Okay, so
Yeah.
can you see it? Can you see my
Yes.
presentation?
Yeah, but not full
Yes,
screen,
yes.
the sorter, slide sorter view.
Okay. Let me go back.
Can you go full screen?
Why did I pause? Just a second. Huh? Let me just start it again. Why is my screen? Let me share again. Okay, now you can see it. Why am I not able to do this? Okay. Now you're able to see, are you?
Yes. Go ahead, please.
Okay, so this is me and Jyoti. Actually, it's basically Jyoti was meant to present it. Jyoti is the lead radiologist at Apollo Athena. And this is a kind of an extension to what Manjula has shown. And here the radiologist, I think, like Tanuja said, you said the spider sense or the sixth sense or whatever you call it. So I think that also comes into play a lot of times. And this was very interesting. This is so I'm going to start off with the first case. So I'm just doing this on behalf of Jyoti. Yeah. So this is a 67-year-old postmenopausal lady who's been having regular mammograms of the past 10 years. And this was reported on mammogram and ultrasound as fibrocystic disease with a few cysts which were showing up every now and then. So the family history is that she had her father and her paternal grandfather had CA prostate. So she was familiar with her nodular breast, which occasionally became tender. So there was nothing new to report. And she got her annual mammogram done in September of 2025. Again, these the mammogram, I don't have the pictures, revealed multiple isodense masses with obscured margins, and this was a BI-RADS 2. An ultrasound was done. It showed bilateral dilated ducts with some cysts showing internal echoes, and they said stable benign bilateral breast masses. So then this lady visited her gynecologist for a pap smear, who examined her, and she felt a vague lump in the right breast. That is when all this happened. This was happening in September, October, and she went back to the imaging center for DEXA scan, and she mentioned to the radiologist about this lump that the gynecologist had palpated. So it was very astute of the radiologist, said that if you're feeling something, we'll let us do an ultrasound again. And so in the site of the palpable mass, now they could see a non-mass-like area at 9 o'clock. And there was increased vascularity also, and a guided biopsy of the right breast lump, and an FNAC of one of those lumps in the left breast, which was slightly larger, was also done. And this is what they found. On the right breast core biopsy, there was low-grade DCIS, and the left breast FNAC, there was benign breast disease. And this is when she came to me. So, oh wait, why did I bring this up at this time? So, okay. So when she came with these things, so Jyoti said, because she's got low grade, let us try and figure out what is the extent of the disease. So on the right side, there was this segmental area of non-mass-like enhancement with internal enhancement from 9 to 10 o'clock. And the entire extent was about 6 to 7 centimeters in the anteroposterior, from nipple to chest wall direction, and about 2.7 into 2.9 in the transverse and CC dimensions. So the findings were compatible with the biopsy-proven DCIS. So you can see that that's the extent of the disease in the anteroposterior direction. But on the MRI, there was also the additional lesion at 4 o'clock, and it had mild diffusion restriction, and it was type 2 curves. But that is when Jyoti said to the patient, I would want to biopsy the left breast lesion as well. So this is how it looked like. So there was a lesion at 4 o'clock. That's the lesion at the 4 o'clock position. And there was another one at 9 o'clock also, which was the inner periareolar edge at 9 o'clock on the left breast. And you can see that on the MRI as well. So she decided to biopsy both these lesions. And the 4 o'clock lesion again came back as ductal carcinoma in situ in a background of sclerosing adenosis. And the 9 o'clock lesion was an intraductal papilloma with usual type ductal hyperplasia. So this lady, she was kind of, she knew that she had these benign lesions, and she said, how would you know whether there is anything else or not? So she just decided to undergo bilateral mastectomies with sentinel node biopsies and a bilateral DF flap reconstructions, both sides. So look at the final HPEs. So, so what my pathologist said is that she could see the entire spectrum of proliferative disease that one would expect in a breast, going from an ADH to a low-grade DCIS. And this finally came back as low-grade and intermediate-grade DCIS. So 107 blocks examined, 30 blocks showed DCIS. And we did a sentinel node also that was negative. This is the right side. And on the left side, there were 3 lymph nodes on the sentinel and frozen, and final was, I think, 4 nodes. And again, 27 blocks out of the 84 that were examined showed DCIS. So pretty much a lot of DCIS for this patient. So this is this case. So I think, it is, again, the index of suspicion. So the left could have been just ignored, and we were all talking about the right breast, but then Jyoti thought that what she saw on the MRI on the left side wanted her to do a biopsy of the left lesion, which was labeled as benign on FNAC. So that is what she did, and that is how.
If I can ask,
yeah.
So if this lady didn't have DCIS on the other side and was an IDC, we may have potentially not done an MRI.
For a 67, but she had pretty dense breasts. She had pretty dense breasts on mammogram. And that is explained by the fact that, she's been having these cystic lesions. So, those breasts, even at 60, 70, you would find that, extensive fibrocystic disease, even at that age, could be a very dense breast. Yeah.
Geeta, can I say something?
Yeah, Tanuja.
ER/PR kya tha? Because see, this is the kind of situation.
ER is positive. ER is positive. Positive on both sides.
Even if you had missed the left, I'm just playing a devil's advocate. She would have got demoxifen, and the other breast would have been fine. Because these low grades and all.
Yeah, it was not that small lesion on the left side. So this is what I'm trying to say. 27 out of the 84 blocks came up with DCIs on the left side.
Okay. So my basic thing is that these women with luminal type of DCIS, they usually have a background of sclerosing adenosis, and either you do a mastectomy or you do nothing at all. These are the only 2 possibilities that help you catch the disease.
So the core biopsy said low-grade DCIS, but now it is low-grade and intermediate-grade DCIS. So she's kind of progressing. We can see that, because over the years, she is kind of slowly progressed to this point, and who knows. The right breast lump was pretty sizable. Clinically also, it was quite sizable. So
and these women will develop a ER/PR positive disease only in the end, invasive cancer. So my thought process is that because she was old and she agreed for a mastectomy, you're in the clear. You had to do a lumpectomy, and then tomorrow, it becomes way.
Follow her up would have been terrible.
Yeah, I know. So because you had a mastectomy, you at least have some spectrum there. Otherwise, this is a nightmare, frankly speaking.
Yes. And also to ask, now that she's got both her breasts off, she's ER positive on both sides. Do you think there is any role for any hormonal treatment at all?
You have to give, because I know you're saying it's a mastectomy, but even in these, how old is she? I'm so sorry, I forgot the age.
67.
67.
So these women, see, I usually say after DCIS in 10 years time, they develop invasive cancer. So if you're sure the mastectomy and all the breast tissues removed, there's no chance of an invasive. But if there's anything
I
less,
can never be sure that I've removed all the breast tissue.
no, I'm
the
just telling
is
you
5%.
that you're very
Data.
lucky to got a
breast tissue
mastectomy
would
in
still
her.
be there.
No,
Yeah,
but if
so
you look
even
at the
after
data, madam, what tamoxifen prevents in
it's
DCIS
contralateral. Yeah.
is contralateral DCIS, ipsilateral IDC and DCIS.
Correct.
If you've
Ipsilateral
done a
IDC is my worry.
right, but if you've done a mastectomy,
Correct. You're safe. Yeah.
then
Agreed.
where is the point of what
Correct.
are we
No need to
discussing?
do anything. Correct.
Yeah.
Already risk reduced to 95%. So
Yeah.
Correct.
So
agreed.
I'm just
yeah,
going
so
to come
that is
in
the
here.
case. It's just
So since we've done a bilateral mastectomy, even if she's ERPR positive, you're saying we don't have to give tamoxifen?
Yes, because you've taken out all the environment that causes the invasive cancer.
So what are we
So there's no right. Okay.
Yeah, no.
So, hello. This is Purvi, radiologist.
Purvi.
Hi. So I'm just this worried here about this 27 blocks coming out positive for this DCIS because the left side on MR is very much kind of it's more of extensive background parenchymal enhancement. It's seen like it's only way to kind of differentiate is probably doing an ultrafast sequence where we might see slight early enhancement as compared to the rest of the parenchyma. This is very challenging as a kind of for us as well as a radiologist. Only a small lesion is visible, and on pathology, so much extensive disease is there.
So what my pathologist said was that they were intact lobules. It is very hard, to and within the lobules is where she's seeing these, the DCIS.
Okay.
Yeah.
Sorry, Geeta, you want to go ahead with your second case?
Oh, okay. So that's also very, it's an interesting from the, like I said, the radiology point of view. Are you able to see? Yeah.
Yes.
Yes.
Okay, so let me go to the next case. Oh, what did I do? No, sorry, I think I got the wrong one. Okay. So the post was a 55-year-old lady with complaint of lump in right breast, mild 1 month duration. So when I examined her, it was a 2.5 into 2 centimeter firm lump with ill-defined margins at 12 o'clock, about 3 centimeters from the areolar margin. Rest everything was good. So on mammogram, it was a well-defined lobulated radiopacity in severe depth, right upper outer quadrant. And on ultrasound, it was anechoic lesion, 2.4, 2.2 into 1.6 centimeters with incomplete septifications within the cyst at 12 o'clock. Now on aspiration,
Geeta, are you still there?
I think she lost her net.
Yeah.
The slides aren't moving.
There, she's back. Hi, Geeta, we can't hear you, and I think your slide share has stopped.
can you see it now?
No, not yet.
Can you can't see it?
Yes, now yes.
I am skilled. Yeah. So this aspiration yielded clear fluid. So probe on the site after aspiration showed a tiny area of vascularity on one edge of the collapsed cyst, which prompted Jyoti to do a biopsy. And that is the cyst. And if you can look at the area where I'm just pointing, this is where she thought there was vascularity. So she, after the cyst had collapsed, she put in a needle which did not, which showed vascularity, and that is what we got. It was an invasive duct carcinoma, grade 3 with DCIS, TNBC with a Ki67 of 35 to 40%. So that is, so the MRI happened after this. By the time that the cyst had refilled, and this is what you're seeing on MRI, it is an irregular, cystic, thick rim lesion, measuring up to 22, 25 into 29 mm, and right in the right breast. And tiny foci are seen anterior to it, increasing the size of 7 mm. There is peripheral diffuse restriction. So this is the post-clip.
Squamous metaplasia?
Nothing at all.
Okay.
There wasn't.
The squamous carcinoma metaplasia, this kind of a story. What you said was it describes squamous carcinomas of the breast.
So I actually have.
This was not squamous.
No, so like I mentioned this case to both Geeta and Tanuja before. I had a patient, 35, 36-year-old, came with a serous, like a cystic lesion in the breast. Aspirate was clear. Ultrasound kept saying there's nothing beyond that. They didn't pick up anything in terms of increased vascularity. But because of nipple discharge, clinically, we chose to go in and look at the wall. And I said that I want to do a microdocectomy and I want to see the wall. And she had metaplastic TNBC.
Wow. Yeah.
And the second patient that we have, and we have a second patient who was upper central, had a 2 centimeter, and this one I think even Shobha has seen at some point of time, had a 2 centimeter lesion, which was on aspirate a galactocele. And she had finished having her children years before, so it made no sense. We wide excised that galactocele, and that was TNBC.
Yeah. So, this is a question. Yeah, please.
Dr. Geeta, just one question. The only thing that sort of raised your suspicion in this case on the imaging was the presence of vascularity and the small speck of calcification, is it? Because otherwise, this rimmed lesion on the MR,
on the ultrasound.
On the ultrasound, we weren't really suspecting anything, correct? It's only the vascularity and that tiny
after the diagnosis.
So this, the MRI happened after the diagnosis. So if you look at this wall, which I'm pointing, that looks a little thickened. And when she had aspirated the fluid, that is the one which showed vascularity, and she thought, I don't know what to say to this, because you keep wondering if you have a cyst. We find so many cysts so many times. So how further should we be going when you have these cysts? Because most of the time say, oh, cyst scenario. It is very scary because this is just
So Purvi,
yes, that's exactly why I asked the question, because I was wondering, what was that thing that actually alerted you to that there's something suspicious, because just the vascularity.
Yeah, after the cyst had collapsed, she could see that and it was not a big in the face kind of vascularity. It was a speck. She could see color there, and that is when she decided that she wants to do a biopsy.
So, Manjula, I'm going to say this. Not all of us have. I mean, I have fabulous radiologists, but not everybody is Jyoti and Purvi and picks up the smaller things. Sometimes it's the simple thing on if the cyst refills really quick, an MRI helps us with that enhancing wall.
Yeah.
And one more thing will go is if there are no other cysts in the entire breast, I'm looking at that cyst very carefully in terms of looking at the vascular, if the wall of the cyst, to pick up something. Fibrocystic disease, single cyst, to have just the single cyst in the entire breast is little less common. Like the entire breast, if nothing is there on ultrasound, other than that one cyst.
I think that's an interesting point also. And I don't know whether everybody else does it, but if I have a large palpable cyst, which I've aspirated, I always get an ultrasound done, making sure there's no solid component below it. So if they were to tell us that, like we said, that there's no additional cyst, there's that single cyst, we either call the patient back on very close follow-up, making sure there's no refill, which is quick. Or I would, I guess, if they tell you it's a single cyst and there's minimal vascularity, biopsies are definitely mandated based on what we're seeing.
And the other thing I think, the learning is that, a lot of times we're tempted to aspirate large cysts in the outpatients when you have a report which says it is a cyst. Like in this case, she came with an ultrasound, which said a mammogram and an ultrasound. The ultrasound said it is a cyst. I could have jolly well aspirated it and asked her to go home, and then, things would have been different. But I always think once you have something like this, you should always get the imaging reconfirmed, because I sent her for a re-image clinically. Like I said, it felt like a lump with ill-defined margins. Although I just said it is nothing and sent her home because she already. But outside ultrasound, I'm a little wary of. I always try and get it cross-checked with Jyoti, and that is where we found this.
Okay. Before we move over to the next set, any other questions? Nobody seems to be paying attention. Feel like no one's
No,
listening.
Nita, that cystic TNBC is still bothering me, but then उसने pathologist को involve ही नहीं किया गीता ने.
Madam, पर है cystic TNBC क्या करें? We are all seeing these weird diseases as clinicians. हमें कुछ पता नहीं कि क्या बोले patient को.
नहीं, ये जो cystic TNBCs है ना, they are very unique morphology. So I just thought, that to squamous I would have bought, but just some non-metaplastic carcinomas generally don't do this. So एक तो छोटा TNBC and I mean Geeta, spider sense.
So we do get these, TNBCs even on MRI. When you see, you'll have this rim enhancement, and the inside is all necrotic and kind of dead. But with purely a cyst and with a wall, that is not usual. Yeah.
Those are more of necrotic, but this is definitely a cyst. It's a wall which is
thin wall है ना, पूर्वी कितना.
Yeah, it is very thin walled on ultrasound. It is not the entire wall probably which is diseased. It's just that posterior wall where there is kind of 1/5 of the cyst wall which is slightly thickened, and probably that's got the vascularity only. It's not necrotic TNBC. It is a cystic disease with wall which is diseased kind of thing.
So there's a question on, can it be papillary cystic carcinoma which are like TNBC?
So that was my first thought, but वो अंदर नहीं है ना. It's not, the lesion is not in the inside of the cyst. It's outside of the cyst. So how it presents, you have cyst within cyst. So that kind of a presentation. वैसा नहीं है इसमें. So I don't know. I have a feeling that invasive is somewhere else, and this is a cyst. The cyst was the means to detect it, I think. I think there is an invasive carcinoma a little away from the cyst. It ended up in the wall of the cyst, but probably the cyst have you excised it, Geeta? Mute.
Sorry, Geeta, you're mute. You need to unmute.
This is a 2.8 centimeter tumor, so we're putting her through neoadjuvant.
एक बार histology double. I know you have very good pathologists with you, but still, because that radiology is very scary. So whenever I get a call from my radiology colleagues, I double check, because if they say, "Arey, madam, this doesn't look like," they have been right in 80 out of 100 times. So just a little careful. But here your radiologist only is telling you that it's cancer. So
yeah. So and now with the MRI, I'm sure MRI looks, that the wall is quite thick on MRI.
Right, thank you. Other than scaring us, Geeta, very little happened.
So all cysts to be taken seriously.
So, Debashri, can we get you to share your screen, please? And you've got very similar cases. I'd request you to start with the main one that you want to present, and then if we have time, we take the second one. Hello?
Yes, I'm sharing.
Yeah.
Dr. Selvi sends her apologies because she's unwell. She's not able to join us. You can see my screen?
Yes, we can.
So it's a case series of multiple atypical lesions that we've seen post-RT in the last 10 years. I'll go through the first case and then give you a summary of the remaining cases. Dr. Nandini, our pathologist, is here with us today. So a 66-year-old lady who presented in 2018 for a right breast carcinoma underwent a wide local with sentinel for a lobular 2 centimeter ER positive lesion. She thereafter also received radiation in 16 fractions of 42.5 gray. And 2 years following her surgery, in her follow-up, a PET showed multiple skeletal metastasis. Thereafter, she was receiving systemic therapy and was under care of the medical oncologist when she developed a further cutaneous lesion over the right upper abdominal wall. Repeat PET scan done at that time did not show any metabolic activity within this abdominal wall lesion, but did pick up a progression in the skeletal metastasis. And hence we went ahead and did an excision biopsy of the abdominal wall lesion. This is what it appeared as. Nandini ma'am, can you describe this atypical vascular lesion for us?
Yes. We received a skin nodule. So what we see is skin with superficial dermis showing vascular dilated vascular channels lined by some atypical endothelial cells with hobnailing, and some vascular channels even showed valves. Next slide. At this point, we did not have any vascular markers or c-MYC. So we advised for an IHC with CD31 and c-MYC, but we couldn't get it done for this patient. After 2022, the patient was lost to follow-up. Can we do the second case also, and then it's all a series of cases. So can we do the second case also?
Why, doctor? I just have to ask that why did you call this was a single lesion and there's nothing elsewhere, and it's in the abdominal wall, you said?
The right upper abdominal wall, ma'am, just below the breast.
So generally, the atypical vascular lesions which are benign, they usually come in the it should be a radiation field. I think
yes,
abdominal
yes.
is not the radiation field for breast.
Yes.
So we'll have to
worry. It was in the inframammary. It was in the inframammary groove and upper abdominal wall junction. It was actually in the radiation field.
So the problem here is that you have a lady with metastasis and you have an atypical vascular lesion. I would worry whether it's an angiosarcoma, which is looking very differentiated. So we need to have some radiology also of the breast, because sometimes we've seen this angiosarcomas looking so subtle that I remember once or twice my radiologist colleague calling me that we would have just observed that lady, but something happened and they biopsied and it was an angiosarcoma. So they're very subtle. So the problem with her is, especially she was metastatic disease quite fast after her after her presentation. So my worry would be that I would probably rule out an angiosarcoma.
Yes, ma'am. That's why we suggested c-MYC for this patient. It was a single lesion. The earlier histopathology was not available for review, but this was a single lesion, and we advised.
Yeah.
Right. Devashri, can you do the second case, and then Nandini can give her comments?
Yes, ma'am. 57-year-old for a left breast carcinoma underwent neoadjuvant chemo and thereafter a wide local with ALND for an ERPR positive 2 centimeter tumor with 3 out of 17 nodes. She received a conventional RT of 28 fractions thereafter. This was in 2017. So 5 years later, at the same irradiated site, she developed a skin thickening which showed no clinical or imaging correlation. Punch biopsy was done, which showed an atypical angiomatous proliferation. So we went ahead and did a wide excision of that skin lesion, which turned out to be angiosarcoma with positive margins. Nandini ma'am.
So this was the initial skin nodule wedge biopsy. It showed similarly a superficial dermal vascular neoplasm with lot of multi-layering of endothelium, and looked very pleomorphic. So I was thinking of angiosarcoma, but with the wedge biopsy, I was not very sure. So I asked for a wide local excision of this lesion. Next slide. So as you can see, there is a lot of layering of endothelium here and quite atypical and prominent nucleoli also. Next slide. So the wide excision clearly showed multiple areas of the vascular neoplasm with lot of endothelial stratification and pleomorphism with prominent nucleoli, and the inked margins were involved. Next slide. So we can see the neoplastic cells forming vascular channels and a lot of pleomorphism. Next slide. So the hobnailing, prominent nucleoli, and a lot of atypical cells. And the vasoformation is also clearly evident here. Next slide. Next slide. So by this time, we had all the vascular markers and soft tissue markers. So we did the panel of markers. EMA was negative to rule out any metaplastic carcinoma. S100 was negative. Next slide. CD31 and CD34 were not very brightly positive. They were patchy and weak positive. Next slide. But ERG and FLI1 were both diffusely nuclear positive. And next slide. And CMYC was clearly positive. So this is CMYC. And I went back and did both ERG and CMYC in the skin nodule as well. Both of them were positive in the skin biopsy also. So this was a clear case of post-radiation angiosarcoma.
So thereafter, we went ahead and did a mastectomy for her. And the final pathology showed an angiosarcoma with 2 atypical scale nodule vascular lesions as well.
Right. So
my only thing is, Neeta, we don't get angiosarcomas. So in both these cases, the vascular lesions is 5 years a short time or 5 years is okay? Because most of our TMH data has been beyond 7 years.
Yeah, I think
we had such a short time.
Slightly longer duration between the radiation and the lesion. But honestly, I mean, after today's day, I'm going to tell you anything happens. So the way
is there anything different that we do? I mean, I'm just thinking loudly, but
so I think, the way what I would take home from this sort of situation is that if you've got something that looks abnormal, your pathologist is able to tell you that there's an abnormality on the wedge, but she can't give you enough of a diagnosis on that. Exactly what they did, which was a good wide excision before planning the mastectomy, I think would be the correct way to go.
In our experience of the last 10 years, we've had 5 such atypical vascular as well as sarcomatous lesions post-radiation induced. We were trying to see what could potentially have been a contributing factor, whether the change from conventional to hypofractionation would have been a contributing factor. But in our case series, there was no consistency at all in terms of the radiation received. And also in terms of literature review, when we went back and looked at it, it showed us that the latency period may be as early as 1 year post-radiation. Most commonly, it can occur within the irradiated field, but it is also possible, or case reports have been reported with lesions outside or adjacent to the radiation fields as well. And given that there is a possibility of progression to angiosarcoma, even though it is rare, most commonly these undergo an extensive excision. However, the diagnostic biopsy that we do has to be surely representative of the underlying lesion so that we're not missing an underlying angiosarcoma. This was the takeaway that we wanted.
Yeah, I think point taken very well. So, Manjula, are you still there?
Yes, I am.
It is 8:30. Should we take the last case? Is everybody game to hang on for another 15 minutes? Somebody say yes or no. I already know the case. Okay. So, Manjula, maybe you can get Sai to present that case and we can run through that case because I think it's a very interesting case.
Sai, can you just share that, please, the slides?
Ma'am. Yes. Just a second.
So before Sai begins, this is actually not a case that this patient was actually a friend of mine, and this has been operated upon by a colleague in another city, or rather treated by a colleague in another city. Yeah, start, Sai.
Okay. So this was a 36-year-old premenopausal lady, P2L2 status, who presented with a feeling of heaviness in the right breast. She was evaluated by a gynecologist in her city. A mammogram was done, which was reported to be normal, and the patient was reassured. However, she was very anxious and concerned and visited an oncologist in her city. Clinical examination showed a vague mass-like or difference in feel in the right breast, lower inner quadrant, 3 to 5 o'clock radian, including the retroareolar region. Mammogram done showed an irregular microlobulated hypoechoic mass with indistinct margins between 4 to 5 o'clock. This was 1 into 0.9 into 0.6 centimeters, 3.5 centimeter away from the NAC. There was adjacent amorphous and fine pleomorphic calcification extending towards the NAC, adjacent multiple hypoechoic ducts with intraductal calcific foci at 3 to 5 o'clock extending between the lesion and NAC. And it was a Birat's 4C lesion. Small right axillary node with mild cortical thickening was also noted. Core biopsy was done, which showed invasive ductal carcinoma grade 3, which was a micropapillary variant. ERPR was strong positive, HER2 negative, and Ki67 40 to 50%. PET-CT done showed metabolically active heterogeneously hyperdense nodules involving the right breast parenchyma, which was suggestive of multicentric carcinoma. Metabolically active right axillary and deep pectoral nodes were noted, which were highly suspicious of metastasis, and no evidence of distant metastasis. Patient underwent right mastectomy with sentinel lymph node biopsy. 2 out of 4 sentinel nodes were positive, and she required an axillary clearance. Final histopathology was reported as invasive micropapillary carcinoma, grade 2. Tumor size was 12 into 8 into 4 centimeters, unifocal. Ductal carcinoma in situ was noted, intermediate grade. Micropapillary, comedo, and cribriform patterns noted. Extensive intraductal component was present, lymphovascular invasion was present, dermal lymphatic invasion was present, and 14 out of 19 nodes were positive, with largest metastatic deposit measuring 1.2 centimeters, and extranodal extension was also seen. It was a T3N3A lesion. That's all, ma'am.
Yes, so Dr. Neeta, I just wanted to comment here that this particular patient, the radiologist who had done the imaging outside told her they had done an ultrasound outside, told her that it was absolutely normal. The gynecologist felt nothing wrong. And also the surgeon, who's a colleague of mine, and I'd asked this patient to just go see her for a check. So she called me saying that, gynecologist has said everything's okay, but I'm a little, I'm still a little worried, and can I come see you? So I didn't see the point in her coming all the way to Chennai. So I sent her to my colleague. And my colleague also says specifically that it's just like some vague sort of feeling in the central quadrant. And there was no indication of this volume of disease at all.
So Manjula, one thing is this is micropapillary carcinoma. Now this tumor it's like it's entirely in the retraction artifact space, so it does not necessarily produce a palpable mass. That's a very common problem with this tumor. But the nodes should have been palpable. My only thing was that there should have been axillary nodes, because these present with, so micropapillary is often multicentric and it presents with, but the nodes are a clue that the patient has a cancer.
So the nodes were not palpable, though the PET scan did show not this kind of this extensive volume, but did show a couple of nodes. but they did not think it was significant. So they went in for they did a sentinel lymph node biopsy, and also the nodes. Then finally it came out positive, and when she did the clearance, the nodes were all tiny, shorty nodes, hard,
Correct.
very
And
typical of
micropapillary,
this
there is no
kind.
point. I always get worried. You should never do a sentinel in micropapillary, because this is the kind of situation, like 30 out of 30 nodes positive, 12 out of 12 nodes positive. And they may not be large, but they are positive. I remember once there was a VIP patient, and frozen they came. It was a micropapillary carcinoma, and the patient wanted a sentinel node. And I remember Vani was there. I quietly told him, Vani, you should do a full axilla. But the patient was a surgeon, and she didn't want to lose her dexterity. So she sent me one node. I said, can you send me one more? And on one section the node was negative, but when I turned the node and made more sections, both nodes were positive. So micropapillary is not. And one more thing, Manjula, please get her HER2 done, because on the specimen, not on the core biopsy, because she's an EIC positive. Micropapillaries often have HER2 amplified.
Positivity. Okay.
So just repeat it, because in the core you may not have had the disease that you got in the final specimen.
Okay. I'm not sure if the IHC was repeated on the final
So get it
histopathology.
repeated,
I'll
because
have to
my
check.
gut
Yeah.
feeling is that HER2 is the problem also here.
Okay. Okay.
I think my take home from this case when we had discussed it was more about the patient pushing for some evaluation and examination. And I think the gist I learned from that was that the rest of us need to really look after our health and get scans done, because this is one of us who's gone through this. And I think it's completely insane that it's a 12 centimeter T3N3A type of disease that she's been detected with.
I know, sad situation.
So, I mean, Tanuja madam and I know I despise the concept of micropapillary disease. I think it is worse than most TNBCs.
Absolutely.
They are the luminal cancers that
Really, it drives us crazy. I've got a patient, we've just been discussing with her. She had a micropapillary solid cystic sort of disease. Invasive component was 8 mm. We had done 7 nodes, not routine sentinel, all were negative. We gave her chemo because it was TNBC. 2 years in, she has a cystic mass, hemorrhagic mass in the interpectoral. And that is now micropapillary disease. And it's not a lymph node.
So the problem with micropapillary is that they hide, they hide in crevices, and they are the ones capable of coming back with late recurrences. Yeah. And interestingly, Neeta, when you put something in it, it becomes a mucinous carcinoma and it becomes a good disease. So that's been my life's work. I have not yet reached a point where I can tell you what it is that changes that.
Correct. So we have to find that something to turn it into
before
mucinous.
I retire, Neeta, before I retire, I'll find. I already found
You've been saying that to me for the last 15 years now.
I found it, but I have to have a publication. Then I can say.
Fair enough. All right. Thank you very much. You've all been extremely patient. And I think I learned a lot. I also got a little scared of a lot of things. But I think the idea is, please reach out and talk to each other. We all see very strange cases. Somebody else may have seen something similar, be able to give you more insight on it. And most of our discussions with our patients need to be very honest and clear, so that we're able to get complete trust with them and be able to have surprises that can be dealt with together. So thank you very much. This is the last of our series of the webinars for the year. We will start the webinars again next year. But the one thing that we will definitely be doing is the masterclass series. I'll send out the first masterclass flyer sometime in the next week or so. And that's going to be on conservative mastectomies. Limited seating, as I suggested, and there will be a very nominal registration fee. It will be on the 23rd of January, just before the YIR starts. So see you all then. Thank you. Happy New Year and happy holidays.
Thank you, Neeta.
Thank you. Good night.
Everybody. Great being here. Bye.
Bye-bye.
Thank you. Good night.
Good night.
Princey, can we also pause the recording and put it up on the website?